Welcome to another EMS Tuesday. Today we're going to cover some intermediate and advanced functions of our Zoll X series monitor. Today we're going to cover vitals uploads to image trend. We're going to cover 12 lead transmissions to the receiving hospitals, ETCO2 monitoring, pacing, and synchronized cardioversion. We'll get started with vitals uploads. A prerequisite for transmitting the vitals is to ensure that we do have a Wi-Fi signal. Again, it's that little antenna at the top with parentheses around it means we have a Wi-Fi, with dots around it means we do not. So as long as we have a signal, we can transmit our Wi-Fi information of vitals to the hospital. Excuse me, not to the hospital, this is for our image trend. So we'll use our return key down here at the bottom right, and then we're going to go up to the middle soft key for log. And then we're going to go to the envelope button, third from the bottom soft key. So it brings up close current case. Closed case is already selected for us, so we're going to use the dot key on the right to select closed case. The case at the top may or may not be the one that you've been working with. You're going to want to look at the date and the time and the duration. If it's just a few seconds or just a couple minutes, and that's probably your morning check or an afternoon check of the monitor, you're looking for something that's probably 15 minutes or more where you've been with a patient. So we're going to arrow down to a previous case here. So we go to select case and we'll hit the dot button. Simply arrowing down is going to skip over the cases. So select case, that brings us into the case selection menu. Arrow down to the case that you want. You can see you have the date, time, and duration. So here's one that's 24 minutes. So we're going to select it, and you see that it brought a green check mark next to it. We can actually select multiple sets of vitals in case the monitor was turned on and off during that patient contact. So we select however many we want, and then in order to get down to the transfer at the bottom, we can't simply arrow down. It will just recirculate through that menu. We're going to hit the home button once, and that brings us automatically to the transfer. We'll use the dot button to select transfer, and it uploads. You're going to look at your percent complete here and make sure that it does get to 100%, and then you'll get a notification at the end that the transmission was successful or unsuccessful. You can also notice at the top here that we have the green light indicating when it was transmitting. So we have disclosure log transfer is complete. If you do get an error, you can try it again inside the ambulance. If you continue to get an error, turn the monitor off, come back to the station, turn the monitor back on, and give it another try. Okay, after the transmission is complete and we have the notification there, we can go ahead and use the dot button to select OK, and we're back to a normal system. Sometimes when monitoring a sick patient's EKG, we may notice ST elevation and reciprocal depression, thus identifying that the patient is having a STEMI or heart attack. We can serve the receiving hospitals best by sending them these details, and we can do that through a 12-lead transmission. We'll cover those details now. Alright, first we'll start off with 12-lead transmissions. And to make this easier to see, we're going to change the monitor to day mode. So we'll hit our return arrow. We'll hit the day-night button. Just the contrast here. Looks like we can read that a little bit better. Okay, first step to a 12-lead transmission is acquiring the 12-lead. So we'll hit our return button. We'll hit our 12-lead button. And we're going to go into the patient stats page, which is the clipboard button here, the second soft key down. We start with the patient's age. Let's say the patient is 46. So we'll hit the dot button to select the age, go up to 46. We'll hit the dot button to accept the age. Say the patient is female. Arrow down to sex. Dot button, change to female, accept. A key to a 12-lead transmission is the hospital won't accept the transmission unless it has some sort of patient identifier marks on it. So we're just going to put the initials of the patient in. So we'll go down to the first name, hit the dot button, and it brings us up to our keyboard. You'll notice over here on the soft keys that we can jump rows or skip columns over here to make the alphabetic selection a little easier. Let's just say that the patient's initials are B for the first name. We can go over here now to save. So now we got the first letter initial. Go down here to the last name, select that. And let's say it's W. So we'll skip some rows here with the soft keys, and then we'll skip some columns over There we go, we have the W, select it with the dot key, and then we're going to go to save. Alright, now we have the patient's age, gender, and initials. Okay, we can either go back to the 12 lead menu or the home screen menu, or we can go straight into the 12 lead acquisition. So we'll hit the button. And for this example, I don't have any limb leads or V leads hooked up, so we get lead fault on all these. But it's still going to acquire the 12 lead and give us our doc in the box interpretation next, which will mention the lead faults. No data available due to efficient 12 lead ECG information. Okay, all the same though, it did store some information here. So to transmit that 12 lead to the hospital, we're going to hit our envelope button over here that has a 12 on it, and then we'll select the hospital that we're going to send it to. So for now, we're just going to send it to the fire department here. So I've arrowed down to the fire department. I'm going to select it with the dot button, and then we use our home button. Alright, after we hit our 12 lead acquisition button, I noticed that we didn't have any Wi-Fi. So we came out here to the ambulance, little change of scenery so we could get some Wi-Fi. So a little side note here, to ensure that we have Wi-Fi, you're going to be looking at this little emblem at the top, the antenna, with little broadcasting marks off of it that kind of look like parentheses. If it has the dots around it, we don't have a Wi-Fi signal. If it has the parentheses around it, we do have a Wi-Fi signal. So a Wi-Fi signal is required to be able to transmit this EKG. Alright. So we're going to arrow down and select the fire department here for the example. So I'm using the arrow keys on the right of the monitor, and then we're going to use the dot key over here on the right of the monitor to select the fire department. And then when you're transmitting vitals, to get out of the selection and go to transmit, you would hit the home button. On this particular menu, you just arrow down until you get past all the selections and go to transmit. Okay, and I've arrowed down to transmit, and I'm going to use the dot button to select it. And up here you'll see transmission complete. So we know that that worked there.
ETCO2, or end-tidal carbon dioxide monitoring. We can use this in a variety of situations, one being a patient in respiratory distress, another one being a patient in cardiac arrest, the latter being one that's near critical. For a patient in respiratory distress, we're going to be monitoring the amount of carbon dioxide they are exhaling, thus telling us how efficient the lung function is in the patient. We can administer nebulized medications like albuterol and actually see a difference quantitative-wise in the figures on there, but also on the waveform that's being presented on the monitor, and actually see the kind of progress that we're making. So there's two ways to obtain ETCO2 with the equipment that we have. The first one being a nasal cannula. So this setup is really similar to a regular nasal cannula, where it has the prongs that administer oxygen to the patient. You can see that it has two tubes in there of varying thicknesses. The thicker of the two tubes is our oxygen tube. And we're going to connect that to a bottle just like we would any nasal cannula. The same flow rates that we would have for normal nasal cannula, 2 to 6 liters per minute. So we have the oxygen applied here for our ETCO2. We've got it flowing, and we apply the cannula to the patient. You'll notice that there are prongs that go inside the patient's nose, and then a little cup down here that's actually suctioning in the CO2 and sending it to the monitor. So we'll do our tomahawk approach here for the patient. The other side of the cannula has this quarter or half turn lure that will apply to the side of the monitor, and I'll show you that momentarily.
Here's a close-up view of how we apply the TCO2 to the monitor. This is in the blood pressure cuff pocket of the monitor. We have this little trap door on this side, and then the port at the bottom. The port at the bottom is kind of deceptive. That is not what we plug it into. That's actually the exhaust system for the TCO2 monitoring. We just open this trap door by pulling it down, and then we insert our half-turn lure lock into there firmly, twist about a half turn. Seems closer to a quarter turn. And once we have that in place, the pump will start up again automatically.
So our first method of monitoring ETCO2 was through the nasal cannula. The second method is the inline ETCO2 monitor. We would use the inline ETCO2 monitor anytime a patient is in cardiac arrest or any type of advanced airway is being utilized. The inline doesn't need the nasal cannula. It does not deliver oxygen. It's simply suctioning a little bit of gas from that tube and telling us what the patient's ETCO2 level is. For cardiac arrest, this can be critical because it can tell us if we're doing good compressions or if the patient is even viable. We would expect to see, for a patient that is in cardiac arrest that is getting quality compressions, an ETCO2 monitoring of 10 to 15. If we see 10 to 15 on our monitor, we know that there's potential for that patient to be revived, that there's still a metabolic process happening in the body. ROSC can be identified almost best by ETCO2. Having this in the setup already, when we see the numbers spike to 55, 65, 70 in the ETCO2, we can expect that we're probably going to find a rhythm at the next rhythm check. We're going to continue to our CPR and go through our full 2 minutes, but at that rhythm check, we can expect to see a heartbeat happening there. So for monitoring ETCO2, we have an advanced airway in for this inline type. So the inline type has a large and a small port. So the larger port fits over the king tube or the ET tube. The smaller side we utilize for the BDM. So we're just going to bag the patient just like we normally would every 5 to 6 seconds during a code. And the other portion has that quarter turn or half turn lure lock that goes into the side of the monitor. Just as simple as that.
Now you can see the waveform happening at the bottom here. The shape of the waveform can determine the patient's lung function. The number over here can determine their level of respiratory acidosis. And we'll go over what you can discover using ETCO2 in another class.
All right, now we're going to talk about my favorite topic, cardioversion. My favorite because it used to scare the crap out of me, and that's why I chose it for the first topic as your lieutenant for education. Synchronized cardioversion or cardioversion in general terrified me because there was a potential outcome of the patient not surviving. But as we covered as a shift, chemical cardioversion can be done pretty smoothly when we work as a team. Chemical cardioversion and electrocardioversion are two different methods, and they're used for two different types of applications. The patient is experiencing the same symptom, which is supraventricular tachycardia. Their heart rate is beating so fast and it's stuck in a loop, and the heart is unable to get out of it on its own. So how we determine whether or not we use chemical cardioversion or electrocardioversion is the patient's presentation. Unstable gets the cable. For our shift, the last 2 times that we've had the chemical cardioversion, the patient's heart was racing, but they were still able to talk to us. They were not faint. They still had a decent perfusion. We weren't seeing signs of cyanosis. They were still conscious. So that led us to have the opportunity to do chemical cardioversion. When a patient is fainted, showing signs of cyanosis, terrible blood pressure, things like that that identify them as an unstable patient, we're going to move to electrocardioversion, synchronized electrocardioversion. That's where our Zoll X series monitor comes in. We've identified them as unstable. We're going to turn on our monitor and pull out our cardiac patches. We'll have these little arrows there, open the patches up, use the diagrams, high on the right, low on the left, just like we would for CPR. We'll prepare the patient for what's going on. At this point, with an unstable patient, they're not likely to even be able to hear us at this point. They're probably fainting, maybe unconscious altogether. So we're going to move right to our work on the monitor.
Typically, when you put pads on a patient, the monitor would automatically select pads and show you what's going on there and put it in CPR mode. Since we're using the simulated pads here, the monitor is not automatically going into it. Or let's say you run into a situation where the monitor is not showing the pads right away. We can use our arrow keys to bring the cursor around. The cursor is the blue highlight there. It generally starts in the plus up in the corner. We're going to arrow down to this first line here. It can be any of these lines, but we'll work with the first one for now. So you see I have lead 2 selected. I'm going to hit the dot button and then I'm going to arrow up to pads. Hit the dot button again to select pads. Now you can see that we're monitoring what's going on with the patient through the pads. It's kind of a small wave there, and if we're trying to determine whether this is regular, irregular, wide, or narrow, we really need to see it better. So next to the leads is selected, so next to pads here, we have the amplification of the wave. We can arrow over to the amplification, select it. It starts at 1 centimeter for millivolt. We're going to change that to 4. So what the monitor is receiving is still the same. We're just zooming in on it. So what we're looking for here to ensure that the patient is in SVT, we're looking for a heart rate over 180. We're looking to see that we don't see P waves in this waveform. If we saw P waves, it would be sinus tach, and cardioversion would not be the recommended course of action. So we see no P waves. Next, we're going to determine whether it's regular or irregular, wide or narrow. If it's narrow and regular, we're looking for starting joules of 50 up to 100 joules for our synchronized cardioversion. If it is irregular and narrow, we're starting at 120 joules and can go potentially up to 200 joules. If it is a wide complex and regular, we'll do 100 joules. If it is a wide complex and irregular, the patient's not conscious anymore. We're actually doing CPR, and that's the case for defibrillation. So we have a regular, narrow rhythm here at 180. So we've determined that this is SVT, our patient's unstable, and we're going to deliver a synchronized electrocardioversion. So to do that with our monitor, we're going to look at the soft keys here on the side. Third from the bottom, a soft key, we're going to see sync. We'll hit sync, and what it's doing is looking for the R waves. Each time that it finds it, it puts it up on top. So each of these dots is where it's synced up at, and you can see the sync light flashing. So we know that we have the potential to be able to shock now. The monitor is ready to do it at the appropriate time. Next, we'll select our energy rating. Again, we determined that it was narrow and regular, so we start at 50 and work our way up to 100 if needed. We'll do our energy selection, bring it down to 50, and we're going to charge the monitor. With defib, we can just tap the shock button and it'll deliver. With synchronized cardioversion, we need to hold the shock button until the shock is delivered because it has to do it right at a specific time. We have 50 joules selected. We'll push and charge. The monitor is ready. We make sure that our crew is clear of the patient, and we deliver the shock by pushing and holding. One shock delivered at 60 joules. It's actually 2 on here because we did this before to make sure that it worked. Now, if our scenario was set up right, we could expect to see the patient momentarily flatline, hopefully come back into a sinus rhythm that's at a more acceptable rate. If we do not get that response, that's when we prepare to synchronize cardiovert again at a higher rate. Now, synchronized cardioversion, you can consider sedation of the patient. It's going to depend on how unstable they are. If your crew can help you get out the Versed and that we can sedate this patient, great. If they're losing consciousness, let's not worry about that. Let's move right to the synchronized cardioversion.
All right, so we have 2 forms of electrical therapy available to us via the, 3 forms of electrical therapy available to us via the Zoll X series. We have synchronized cardioversion, we have defibrillation, and on the other end of the spectrum, we have pacing. Defibrillation, when the heart's out of control, it's not actually producing a pulse, the patient's in cardiac arrest, that's when we use that. Synchronized cardioversion, patient's conscious, possibly. The heart is beating, producing a pulse, and going very rapidly. Pacing is on the opposite end of the spectrum. We're still getting a pulse, possibly not a radial pulse because their blood pressure would be so low. But we got a carotid pulse present, and the beats are below 50, probably in the 30s or 40s, where we're really going to be concerned about that. So if your patient is heart rates of the 30s and 40s, and they are unstable, do not hesitate to get out these patches. These patches are very expensive, but that should never determine how you treat your patient. If the patient's unstable, get the patches out, put them on their chest, and we'll start doing the pacing function of the monitor. Patches go in place just like they do for synchronized cardioversion, just like they do for defibrillation. You follow the diagram, high on the right, low on the left. Hook it to the monitor via the regular cables setup. Now we'll go into the details on the monitor.
All right, now we're going to be monitoring the patient's heart rate. We can silence the alarm up here in the upper right-hand corner. Click that once for a 90-second silence. We would have a 4-lead already attached to the patient, likely a 12-lead at this point, so we would be having data come across here. But in this case, we've determined that the patient's unstable and that we're going to need to start pacing him. The cardiac patches have been applied to the patient's chest. It should show up here automatically labeled pads. In case it doesn't, we've arrowed down to the top row there. We're going to select it, arrow up to pads, select that. Now we're monitoring the patient's heart rate via the pads. Almost always with pads, the amplification shows up really low and it's really hard to determine. I mean, what was that tiny little dot there? So we're going to scroll over from pads to the amplification setting. We're at 1 centimeter per millivolt. We're going to change that to 4 centimeters per millivolt. Now we can see a little bit better what's going on there. Still, that's pretty scary what's happening there. We got a rate probably in the 40s. That's pretty low. So when we see a heart rate like that and a rate like that, we can confirm it with the radial pulse check. At this point, the patient's instability should not be offering you a radial pulse. So if the blood pressure is low enough, we're not going to feel a radial pulse anymore. So you're likely not to feel a radial pulse. Patient's unstable. They've got signs of fainting, cyanosis, low blood pressure. So we've got the pads on them. We're now monitoring through that, so we're going to start the monitor's pacer function. Down here at the bottom, we hit the pacer button, and we change it from demand mode to fixed. This ensures that the pacing continues. If the patient becomes conscious again because of the pacing, their heart tries to take over. We end up, if the monitor goes from demand, or is on demand mode, then it would turn off. The patient ends up passing out again, so let's just keep it on fixed. This is not going to be comfortable for the patient, but they are passing out at this point. We can also consider sedation, and this may be something where we start the monitor, get them going, and then we offer sedation after we get it going. Okay, so we've changed the pacer mode to fixed. Now we've got our rate at 70. Let's change our rate up to 80. Using the arrow keys to come down to rate, dot key to select, change the rate to 80, and then select it again. And now our output starts at 30 millivolts. So what we're going to do is we're going to start the pacer, and then we're going to adjust our millivolts up until we see an electrical capture. And we're going to be feeling for a pulse. Since we're probably not going to have a radial pulse at this low of blood pressure, we're going to be feeling for a carotid pulse. And we want to make sure that we're not at that rate at the 40s anymore, or 30s, that we're actually coming up to this rate of 80. So we'll start the pacer, and then we increase the millivolts till we see electrical capture. Then we'll increase the millivolts until we get mechanical capture and actually feel a pulse. So we're arrowing down, we're starting our pacer. The monitor starts recording it, and you can see the millivolt rating there. Now we're going to arrow back up to our output, select that, and we're going to start increasing our millivolts. Now you can see on here all the pulse marks that are happening there. On a real patient, we would be seeing their mismatched heart rate against where the pulse is trying to be created. So we would see one every few, and then once we arrow up enough and create enough millivolts, we'll start to see the cardiac rhythm match the pulsed rhythm. At that point, we want to go 10 millivolts higher. We're going to check a carotid pulse and make sure that the carotid pulse matches the pulse on the monitor. Once we have that, we can continue at that millivolt rating. If we are not feeling a matching carotid pulse, we increase the millivolts until we feel a matching carotid pulse. We're going to get fluids going at that point and try and get their blood pressure up to a level where we can rate a radial pulse. And then when we get to the hospital, after they're ready to take over, we can turn the pacer off. And this is not just simply the home button, we're just going to arrow down to turn pacer off. So we'll hit the dot key to select, and then come down to turn pacer off, and then dot key. And that's all there is to pacing.
Today we've covered vitals uploads, 12-lead transmissions, ETCO2 monitoring, synchronized cardioversion, and pacing. I know this new video format of classes it's got a lot to be desired. The video quality is poor, the audio quality is poor, and my editing skills aren't there yet. We'll get better, and you'll hear from other instructors. So thanks for hanging in there. See you next Tuesday.